of embryonic and endometrial diagnostic testing. Recurrent implantation failure is a very significant concern for both patients, but also the providers who care for them. During my talk here today, I'm going to plan to talk about defining recurrent implantation failure, trying to understand the limitations surrounding recurrent implantation failure's definition in the present literature. We'll briefly talk about some of the pathophysiology, and we'll try to discuss the contribution of the embryo and the endometrium to recurrent implantation failure. So RIF is fairly uncommon, and it's an imprecisely defined clinical disorder. And this is when we fail to achieve pregnancy after multiple embryo transfers. There's many different potential etiologies, and that has led to an incomplete understanding and provides significant diagnostic and therapeutic challenges. In general, careful clinical evaluation can uncover treatable causes, many of which are known quite well to this group, so thyroid dysfunction, submucosal fibroids, tobacco use. However, more subtle causes require more targeted assessment and can potentially lead to quote-unquote add-ons in our field. So things like polyps or intrauterine syncytiae are common and easily treated. Some of the molecular and cellular abnormalities provide difficult therapeutic challenges as well as diagnostic challenges. These are things which can include progesterone resistance, shifts in the window of embryonic receptivity in the endometrium, and immunologic disturbances. Essentially, a more complex and standardized definition of recurrent implantation failure would be helpful. One of the first challenges in this discussion, as I've noted, is how we diagnose RIF. If we can't diagnose it uniformly, it's very difficult to research the disease. If we can't research the disease, it's difficult to study its prevalence. And if we have an ill-defined disease, how do we compare literature across different diagnoses in different patient populations? So if we can't assess the literature based on the disease, how do we come up with novel interventions? And this is really the crux of the problem with the literature that surrounds RIF. One of the things is, how do you define implantation? There are a number of different forms which are out there. Some of them can be just serum beta-HCG as a surrogate for trophoblastic invasion. And this doesn't account for the transfer order of embryos. It could be the number of gestational sacs divided by the embryos transferred, but this doesn't account for embryos that were lost prior to the first ultrasound finding. It could be sustained implantation rate, so the number of embryos with cardiac activity divided by the number of embryos transferred. But there then has to be a distinction between implantation failure and miscarriage. In general, as I've mentioned, no universally agreed upon definition. Several that have been used is failure to achieve pregnancy after the transfer of 4 or more good quality embryos. Others have used 3 or more. Some propose alternate cutoffs which utilize age or known ploidy of the embryos, considering 2 or more failed transfers in appropriate populations. Again, a critical problem with all of these definitions is that there may be other factors influencing implantation that are not accounted for, such as ploidy, length of fertility, uterine age, lifestyles, uterine structural abnormalities, etc. Broadly speaking, we can kind of categorize these into embryonic, maternal, and then embryo and endometrial dyssynchrony, and we'll talk a little bit about each of these. So in terms of maternal factors, one of the main things that we have come to note, and this was really, I think, initially pioneered by Dr. Shapiro, and this was in 2016, which looked at embryo and endometrial dyssynchrony with increasing maternal age. And he'd found that 50% of transfers were asynchronous in women under age 35, whereas over age 35, 68% were asynchronous. So we do have this issue of embryo and endometrial synchrony, and we'll revisit this in a moment. One of the other things that is quite well known is the increasing maternal age and aneuploidy of embryos. This study and others have shown that there is a reliable increase in aneuploidy due to meiotic errors as maternal age increases, particularly over age 37 or 38. Infection. So patients who have RIF may very well have chronic endometritis. There have been some studies which have been done which looked at infertile patients that found elevations in chronic endometritis, particularly those with recurrent implantation failure. The chronic endometritis can be diagnosed with histologic examination or visualization during hysteroscopy or by bacterial culture. Immunohistochemistry staining for CD138 can help provide a more accurate diagnosis, although the standardization of this has not been entirely established. One of the things that we have seen is that the prevalence of chronic endometritis in patients with RIF was found to be elevated in several studies. There have been some studies which have been looking at trying to diagnose chronic endometritis using a molecular-based RT-PCR test, which can improve the specificity of the diagnosis. The implantation rates for patients who were cured of their chronic endometritis were improved compared to those that were not. And in some cases, as has been shown by Moreno et al. In 2016, it may not be necessarily a chronic infection, but rather changes in the microbiome. The reproductive tract is, of course, lactobacilli dominant. And in this particular study, they showed that live birth rates were increased in patients that had lactobacilli dominance as compared to those that had spontaneous abortions or were not pregnant. Just to briefly touch on anatomic abnormalities, of course, we know that uterine pathologies can assuredly cause implantation failure. These are things like polyps, myomas, and adhesions. Most of the time, these can go unnoticed at the time of standard 2D transvaginal ultrasonography and often would require additional investigation with a saline sonogram or the gold standard hysteroscopy. One of the things that we know is that hydrosalpinges can negatively impact implantation. And there have been several studies looking at this with improvement in implantation if the hydrosalpinx is removed. And we'll talk a bit about that in a moment. We'll talk a little bit about some of the interventions which we can think about for recurrent implantation failure. One of the things is to kind of optimize your IVF treatment. One of the things to consider would be a frozen embryo transfer, which is certainly becoming much more prevalent. Shapiro had noted that clinical pregnancy rates and ongoing pregnancy rates were significantly higher in those that were undergoing frozen embryo transfer compared to fresh. This has to do, again, with that embryo and endometrial synchrony, which we'll talk about in a moment. As noted, there has been a significant increase in the rate of frozen embryo transfer, and there are some potential other benefits with a decreased risk of preterm birth, low birth weight, and gestational age based upon a frozen embryo transfer compared to fresh, which has been shown in a Finnish study and several other studies. We'll talk a little bit about dyssynchrony related to stimulation. So this graph here shows that we have HCG administration After the HCG administration, at some point, progesterone levels rise. The egg retrieval is completed. Embryos will develop in the laboratory over a period of time. The endometrium develops its window of receptivity or ability to accept the embryo over a period of time after the progesterone rises and stimulates that progression. One of the things that we can think about is HCG administration can cause a premature or more robust rise in progesterone than a natural LH surge. And that may shift our window of endometrial receptivity forward, which then will cause potentially dyssynchrony with the embryonic development in the laboratory. So if we think about this, we will have our embryos developing in the laboratory. We can see ones that develop quickly on the bottom and progressively less so on the top. And these embryos that develop in the laboratory may in fact be reproductively competent, but are just falling outside of the window of embryonic implantation. One of the things that we can see as noted is that progesterone rise may cause the endometrial window of receptivity to shift 18 or maybe as much as 24 hours. And therefore, we have embryos which are developing more slowly, which are falling outside of the endometrial window of implantation. We had looked at this with a retrospective study done from 2009 to 2013, and practice shifts in our practice allowed for distinction between embryos that were transferred on day 5 in a fresh cycle, day 6 in a fresh cycle, or frozen embryo transfers. All patients who had elevated progesterone levels were excluded from the study. In this particular group, the fresh day 5 transfers, there were 822 patients. And we can see that for patients that had embryos which were deemed to be early, so on day 5 they were assessed as morulas or B1s, they have lower implantation rates than embryos that were deemed to be more advanced or in that embryonic window of implantation, B2s to B6s. When we look then at fresh day 6 embryos, these are embryos that now all have made it to the B2, B6 range, and any embryos that might have arrested in development over the day 5 to day 6 were then not included. There were 763 patients in this group, and despite having time to develop and now being morphologically equivalent, there was still a difference seen, particularly in those over age 35. We then looked at the frozen embryo transfer as a method of trying to standardize the embryonic window of receptivity and the endometrial window of receptivity. And in this group, we had 718 patients, and the pregnancy rates were equivalent in the two groups. Despite having on day 5 been graded morula B1 versus more advanced B2 to B6, they were all frozen at a more advanced stage and then placed into the uterus at a synchronous time. We'll talk briefly about antibiotics for chronic endometritis. As noted, patients who have chronic endometritis diagnosed via hysteroscopy culture or via endometrial biopsy. Antibiotic therapies have been shown to be effective in curing these infections, these chronic infections. Implantation rates, clinical pregnancy rates, and live birth rates have all been shown to be improved in patients who were able to be treated versus those that had persistent infections. There are several studies which are ongoing to look at new diagnostic criteria for chronic endometritis to standardize it further. And then there are other trials which are ongoing to look at different forms of antibiotics which might be helpful in treating chronic endometritis specifically. I think a really interesting area of this of chronic endometritis treatment is the use of probiotics. The probiotics are, of course, live microorganisms. The formulations may be safe and effective alternatives to antibiotics for imbalance in the microbiota seen in the urogenital tract. I think that one of the things that is an issue with probiotics is that their use is not standardized. The production of the probiotics is not necessarily uniform or necessarily governed by any regulatory agencies. So I think that this is something that is interesting. There are several studies that I'm aware of that are going on looking at their use. Some of them have not necessarily shown promising results, but I think this is an area of interesting further research. Anatomic interventions such as correcting intrauterine pathology. I have this slide here and it can be utilized in order to look further in the future, but really this is removal of polyps, myomas, adhesions, and septums. The gold standard for the evaluation and ultimately treatment would be hysteroscopy. Some of the other anatomic interventions is the removal of hydrosalpinges. There have been several studies, some of which are quite old now, looking at improvement in live birth rate for those that underwent salpingectomy versus those in the control group. I think that patients who have recurrent implantation failure, it should be evaluated for hydrosalpinges with the use of a hysterosalpingogram in order to be able to detect whether or not these exist. And if they do exist in patients that have recurrent implantation failure, I think it's reasonable to consider removal. One of the things that I think is interesting is the concept of endometrial injury. There have been several studies which have looked at endometrial injury prior to implantation, which might help with decidualization and preparing the endometrium for implantation. One of the mechanisms is the production of local cytokines in wound healing, such as leukocyte inhibitory factor and IL-11, both of which are important when it comes to implantation. One of the first studies looking at this was Barash et al., and this was back in 2003, and found significant improvements in live birth rates. There have been other studies which have showed this similar type of improvement. There was a Cochrane review which looked at several different studies, and there was, it stated kind of only moderate quality evidence for endometrial injury done day 7 of the previous cycle. One of the things that we have to focus on is the fact that there is not an agreement on the degree of injury, the number of injuries, or when in the menstrual cycle the endometrial injury should occur. This is a fairly widely used intervention, although I don't know that there is entirely sufficient evidence in terms of the strict protocol on how to actually perform the endometrial injury. We'll kind of talk about Dr. Pertea's study, which was published just recently in Fertility and Sterility. I think that this helps to get at whether it's the embryo or the endometrium in some regard. This was a study which looked at patients that had normal endometrial cavities, normal morphologic development of the uterus. So this is an important factor. This really tries to focus only on the embryo. These were patients that underwent IVF with PGTA and had frozen embryo transfers. This was only data from one retrieval. So from their first retrieval, if they had 3 euploid embryos, they underwent 3 sequential frozen embryo transfers. So if they had implantation in the first, they were dropped out of the study. If no implantation, they had a second transfer. If no implantation, a third transfer. In general, what Dr. Pertea found was that with 3 sequential single embryo transfers, the likelihood of a fetal heartbeat was 95%. The chance of a live birth was 93%. And overall, the chance of having miscarriages was not substantially increased with 3 sequential single embryo transfers. The conclusions are that patients who have recurrent implantation failure after 3 successive frozen embryo transfers, these were single embryo euploid transfers, has an incidence of probably less than 5%, which I think gives pause to think about many of these other investigative things that we're trying to look at. So sometimes one of the things to try if a patient has implantation failure is another embryo transfer. And that can be a very difficult thing for providers as well as for patients. I'll kind of close here with a discussion of endometrial receptivity. These are, implantation relies, of course, on the crosstalk between the embryo and the endometrium. The possible mechanism for recurrent implantation failure is a change in this window of implantation. This has been popularized by several different tests which are available, one of which is the endometrial receptivity array test. This was a test which really had looked at a number of different genes which were expressed, and they were found to be either receptive, pre-receptive, or post-receptive. And there was an initial study which had looked at patients that had recurrent implantation failure versus a control group, and had found that when the personalized embryo transfer was utilized, that they had equivalent outcomes. A similar study was conducted in Japan several years later, and they did not find a significant difference. I think that the endometrial receptivity array test is still under evaluation. There have been a number of studies just recently that have come out. We'll review those briefly. One of them, published in RBM Online in 2020, was a multi-center open-label randomized controlled trial. Analysis on analysis on intention to treat were comparable between groups. Per protocol analysis did not find that the live birth rates were different. However, cumulative pregnancy rates were different. One of the concerns with this is that there was a 50% dropout of patients compared to the 30% planned in the study. A subsequent randomized controlled trial looked at endometrial receptivity array on the first euploid transfer. So again, this is not recurrent implantation failure patients, but these were patients that were randomized to undergo personalized embryo transfers utilizing endometrial receptivity array versus standard embryo transfers. In this particular study, there were no differences in live birth rates, clinical pregnancy rates, or positive HCGs. And so the conclusion for this was that for patients undergoing their first embryo transfer at any rate, the endometrial receptivity array guided and frozen embryo transfer was not a helpful adjunct. There was a study recently presented at ASRM. I believe it is in the process of being published. I recently checked with the authors, and I think that it is coming out soon. But they looked at randomized controlled trial utilizing a single euploid blast transfer. And in this particular study as well, there was no differences in live birth. Again, I think that these were patients or studies where recurrent pregnancy loss or recurrent implantation failure patients were excluded from the trial. So it's difficult to discuss the use of endometrial receptivity array in this context. So I think in conclusion, recurrent implantation failure really needs to be better defined to optimize research on interventions. Potential treatments to consider for recurrent implantation failure. trying to optimize embryo development. So considering extended embryo culture, which I think is becoming much more of the norm. You can optimize embryo ploidy. So considering PGTA, again, I don't know that PGTA is always going to be a treatment for recurrent implantation failure, but it could be something that could be taken off the table in the cases particularly of patients of advanced maternal age. Optimizing embryo and endometrial synchrony, so considering frozen embryo transfers over fresh. Ruling out intrauterine pathology with a hysteroscopy. Evaluating and removing hydrosalpinges, so a hysterosalpingogram and laparoscopy. Ruling out or treating chronic endometritis. This is with endometrial sampling, antibiotics. Again, I think the jury is still out on probiotics. Endometrial injury. I think this could be of uncertain benefit. However, it could be accomplished during endometrial sampling for chronic endometritis. And then, of course, lifestyle modification, smoking cessation, weight optimization. I didn't talk a lot about BMI, but I do think that BMI is a concern when it comes to recurrent implantation failure, and optimizing that is important. Certainly more research is required when it comes to immunotherapy, so glucocorticoids, PRP, and GCSF, the installation of HCG at the time of transfer or before transfer, anticoagulation treatment, and the endometrial receptivity array. I think all kind of are things which are certainly areas of active research, but we need a little bit more before they can become a standard part of treatment for recurrent implantation failure. And with that, I'll conclude. I appreciate your attention, and I very much appreciate being